Welcome back. Have you ever stopped to wonder why the signs of vestibular neuritis are so predictable? It's actually not a mystery at all. The answer is written right into our anatomy. In this explainer, we're going to trace the neural pathways all the way from the inner ear to the brainstem to see exactly how the body's wiring dictates the clinical picture. Hey everyone, I'm from Australian Dizziness Clinics. Everything we're talking about today comes straight out of our comprehensive clinical review on vestibular anatomy. It's really designed to build a solid bridge between what you see in the textbook and what you see walking into your clinic every day. Okay, so let's get right to the core puzzle. When a patient shows up with vestibular neuritis, especially that really common superior nerve type, their symptom pattern isn't random. It's incredibly consistent. But why is that? As we're about to see, the answer is literally hardwired into our anatomy. So the first piece of our puzzle starts right here, out in the periphery, with a structure called Scarpa's ganglion. Its very precise organization is really the key to unlocking why vestibular neuritis looks the way it does. Just look at the strict division of labor we have going on here. Scarpa's ganglion isn't just one big uniform bundle of nerves. Nope, it's split very cleanly into two distinct parts. You've got the superior division, which takes care of the anterior and lateral canals, plus the utricle. And then you have the inferior division, which exclusively serves the posterior canal and the saccule. This clean anatomical split is the absolute first clue to solving our puzzle. And here it is, the clinical payoff. Since it's usually the superior division that gets hit in neuritis, we see this very specific test signature. The horizontal video head impulse test, the one checking the lateral canal, it's going to be abnormal. The ocular VEMP, which tests the utricle, will also be abnormal. But here's the kicker. The cervical VEMP, the C-VEMP, is totally normal. And why? Because the C-VEMP tests the saccule, which gets its nerve supply from the unaffected inferior nerve. See, the anatomy perfectly predicts the test results every time. Okay, so now let's follow that signal from the periphery as it moves into the central nervous system. These nerve signals from Scarpa's ganglion all arrive at this critical hub called the vestibular nuclear complex, or VNC. It is so important to think of the VNC not as some simple relay station, but as a really sophisticated central processor. As you can see right here, the VNC itself is actually a collection of 4 major nuclei, all hanging out on the floor of the fourth ventricle. We've got the superior, which is also known as Becherou's nucleus, the lateral, or Dieter's nucleus, the big medial nucleus, called Schwalbe's, and finally the inferior, or Roller's nucleus. And as we're about to see, each one of these guys has a very specialized job to do. This image really just drives the point home, doesn't it? The VNC isn't just listening to the inner ear. It is a true integration hub. It's constantly getting signals from our visual system, from our body sense of touch and position, the whole somatosensory system, and of course from the cerebellum. It then takes all this data, computes it, and orchestrates everything from our most basic reflexes to our conscious perception of moving through space. It's incredible. Now, if we dive a little deeper, we find these really specialized neuron classes inside the nuclei. First up, you have the PVP, or position vestibular pause neurons. Just think of these as the absolute workhorses of the vestibulo-ocular reflex, keeping your eyes steady on a target. But they do something clever. They pause during fast eye movements, or saccades, which stops you from getting blurry vision. Then we have the vestibular-only, or VO neurons. These are crucial for something called velocity storage. It's the brain's way of kind of extending the sensation of turning, which helps us perceive low-frequency motion. And finally, the floccular target neurons, or FTNs. These are the direct hotline to the cerebellum, allowing it to constantly tweak and fine-tune our reflexes. So we've got the peripheral organization and we've got the central processing hub. Now let's connect these two pieces to really understand the most dramatic sign of acute vestibular loss, that spontaneous nystagmus. The entire phenomenon hinges on a beautiful mechanism called commissural inhibition. All right, so in a healthy, resting state, both the left and right vestibular nuclei are just firing away at a steady baseline rate. As you can see here, they're connected by these inhibitory pathways, which creates this perfectly balanced push-pull system. As long as the signals from both sides are equal, your brain interprets this as, I am standing still. Simple as that. But now, let's throw in an acute lesion. Let's say vestibular neuritis just knocks out the right side. All of a sudden, that input from the right inner ear is gone. The right vestibular nucleus just falls silent. But, and this is key, the left nucleus has no idea this happened. It's just firing away at its normal, steady rate. With absolutely nothing to oppose it, the brain now interprets this relentless firing from the healthy left side as a powerful, non-stop head turn to the left. And here is the final beautiful step. The brain thinks the head is turning left. So, to keep the world stable, the vestibulo-ocular reflex kicks in and drives the eyes slowly to the right. That's the slow phase, the drift. But the eyes can only go so far before they hit their limit and have to reset. So they snap back to the center with a fast movement, a saccade. This cycle, slow drift and fast reset, is spontaneous nystagmus. And since we always name nystagmus by its fast phase, that's why it always beats towards the healthy, more active side. The physiology of the imbalance creates the clinical sign we see at the bedside. So let's just nail down our 3 key takeaways from all this. First, when it comes to the vestibular nerve, anatomy is destiny. That strict topographic division of Scarpa's ganglion is precisely why test patterns in vestibular neuritis are so predictable. Second, the vestibular nuclei aren't a monolith. They're a team of specialists. Think of Dater's nucleus for posture and the medial nucleus for gaze stability through the VOR. And finally, that violent spinning feeling in acute vestibular loss, it all comes from a simple imbalance. The principle of commissural inhibition explains exactly why that powerful spontaneous nystagmus happens and why it beats toward the healthy side. So, we've covered the peripheral nerve and the central nuclei. In our next explainer, we're going to get into the critical role of the cerebellum and trace that famously efficient 3-neuron arc of the VOR. We'll follow the signal the whole way, from the hair cell right up to the eye muscle, and we'll see how specific parts of the cerebellum, like the flocculus and nodulus, are in charge of fine-tuning all of our vestibular reflexes. Thank you so much for joining me for this explainer. For more resources for both clinicians and patients on all things dizziness, vertigo, and imbalance, please visit us at australiandizzinessclinics.com. And hey, if you found this helpful, please subscribe and leave a rating. It really does help other clinicians find this content.